Hello everyone, and welcome to our very first Advanced Therapeutics Webinar for 2025. It's an absolute pleasure to join you all today. I'm Paula Bray and I'm Director of Research for the Sydney Children's Hospitals Network. Before we get started, I'd like to begin by acknowledging the traditional owners of the various lands on which we're all meeting today. This webinar is being hosted from the traditional lands of the Gadigal and the Bidjigal peoples of the Eora Nation in the east and the Barramanigal people of the Darug Nation in the west of Sydney. I'd like to pay my respect to elders past and present and acknowledge the community members, Aboriginal staff, services and organisations who work closely with us to improve the health and well-being of children and young people, their families and communities. I'd like to warmly welcome you to this, which is our first Kids Advanced Therapeutics webinar for 2025. And today we will be hearing from Dr. Himanshu Popat and Associate Professor Atul Malhotra. Dr. Himanshu Popat is the clinical lead and co-director of the Grace Centre for Newborn Intensive Care at the Children's Hospital at Westmead. He is a senior clinical lecturer at the NHMRC Clinical Trials Centre in Camperdown, Sydney. He also co-leads research at the Grace Centre for Newborn Intensive Care. Associate Professor Atul Malhotra is a senior neonatologist at Monash Newborn at Monash Children's Hospital and a research academic in the Department of Paediatrics at Monash University. Collectively, their presentations will focus on stem cell therapy for neonatal conditions and explore the opportunities and challenges involved in translating preclinical data into the clinical setting. Following the presentations, we'll move into a Q&A session, which we really hope will foster some good discussion. So please, as the presenters are working through their presentations, submit any questions you have using the Q&A tab, which is in the bottom of your screen in the Zoom controls. And you'll see that if there's a question that you'd really like to have answered, you can upvote those questions by clicking the thumbs up beside the question. So without further ado, we'll get going for today, and I would like to invite Atul to begin his presentation. Thanks very much.
Right, hopefully you are seeing my screen, which should come up on slideshow. Is that okay? All right. Thank you for the opportunity to speak at this forum. Like Paul has already mentioned, I work at Monash, and I'm going to be sharing some of the Melbourne experience from translating cell therapies for neonatal conditions. So to start off with, I'll just like to acknowledge my group, my cell therapies group at Monash University and at the Hudson Institute of Medical Research, and our larger science team, which is headed by Professor Susie Miller, who is the head of the Ritchie Center, which is the largest perinatal research center in Australia. Now, there's a number of other organizations listed here. They are either our supporters, our funders, or our industry partners. But I just like to declare here that I do not have any financial conflicts of interest in any of the cells which we are working on. So to start off with, I want to just touch upon what are stem cells and what are cell therapies. Commonly, these two words are used interchangeably. Stem cells are different to stem cell therapies because not all cell therapies are stem cells. So stem cells, as you might be already aware of, have two important properties. One, their ability to regenerate or replicate on their own, so divide and keep growing on their own, but also their ability to differentiate into different cell types and organ tissue types, if you like. So, for example, a hematopoietic stem cell should have the property to be able to not just lead to red blood cells, but also white blood cells, platelets, and so on. So, it's important to understand the differences between stem cells, which have those two properties, as compared to cell therapies, which is any biological cell which might be used for therapeutic purposes, which may or may not have stem cell like properties. So cell therapies encompass a lot of other cell types which do not have necessarily those two properties. They might have the property to help either protect or regenerate or repair tissue damage, but they may not necessarily qualify as a stem cell. So I really want people to be aware of that. Now, there are a number of stem cells or cell therapies which are already in either clinical use or research trials at the moment, and I've listed a few of them here. What we are focusing on in our research group or in our preclinical work has mostly been related to gestational tissue, which is the placenta, the amnion and the chorion layers of the placenta, the umbilical cord, and that includes the umbilical cord blood as well as cord tissue, which is the Wharton jelly. So just touching upon cell therapies in general, what are the mechanisms of action? And because this is a neonatal forum, I'll just focus on a condition of neonatology, which is bronchopulmonary dysplasia. So a number of pathways exist where babies who are born preterm go on to have lung problems, and this may include infections, inflammation, high oxygen exposure, and all that leads to a normal alveolar structure in the lung moving on to a dysmorphic, disorganized structure in this model shown as hyperoxia lung injury or bronchopulmonary dysplasia like. And a number of processes happen during this time. And what stem cells might do, or cell therapies like MSCs, the most commonly well-known stem cell variety, which are mesenchymal stromal cells, is they produce various cytokines, pro and anti-inflammatory cytokines. They might produce growth factors like VEGF, which is vascular growth factor, or may have antioxidant and other anti-inflammatory properties. And all these uh, things in total will may protect or repair those damage which might be happening in that condition. Now, what I've got at the bottom of the slide, which is from a paper, as you can see, is that those MSCs can be of various sources. They might be from the bone marrow, they might be from the umbilical cord blood or cord tissue, they might be from the placenta, they might be from the adipose tissue. Mesenchymal cells are in every part of our body, and many of them they can either have stem cell like properties or they can be engineered to have stem cell like properties. But what I want to highlight here is that not all MSCs are equal. So when someone says I'm working on MSC research, it's very important to identify what type of MSCs, what is the source of the MSCs, because every MSC might have a different mode of action, as highlighted in this paper, which showed that when you give MSCs derived from the bone marrow versus MSCs derived from the cord tissue, their mechanisms of action might differ. They both might be beneficial, but how they work might be different. Some of them might have more anti-inflammatory properties. Some of them might have more growth factor promoting properties. So I like to always talk about stem cells in my cell therapy talks as if you do not know your stem cell or the cell therapy you're working with, it's probably not okay. And it's really imperative that scientists and clinicians working with any cell therapy know their cells really well. And this is a classic paper by Dominici et al., which showed that, if you wanted to work with one particular type of MSC, you need to know what are those properties which in vitro identify them as those MSCs, and growing them in clean culture to be able to sustain those properties is really, really important. So I cannot highlight this slide enough. If you take one thing away from this talk, please do not work in cell therapy or stem cell work if you do not know your stem cell. All right, so coming to Monash and our neonatal cell therapy work, we are very proud and privileged to be one of the most active neonatal stem cell or cell therapy groups anywhere in the world. So to date, we have completed 3 trials, all of them safety and feasibility trials in babies, and we have 3 ongoing trials in the red in our babies. Some of these trials have used autologous cells. This is the baby's own cells. Now remember, not all of them are stem cells. And some of them have used allogeneic cells, someone else's cells or donor cells. We have used cord blood cells or cord blood derived cells, and we have used amnion epithelial cells. And I'll just walk you through a couple of those trials just to give you an idea of how it is to try to translate some of the preclinical work into clinical trials. So I'll start off with our first cell, which we translated into clinical trials, which was the amnion epithelial cell. The amnion membrane in the placenta is a rich source of human amnion epithelial cells. And a few years ago, around 15 years ago, scientists at the Ritchie Center and Hudson Institute found that these cells may have pluripotent properties in vitro. They also had very low immunogenicity, and that made them a very good source of allogeneic transplant for cell therapy. So they are kind of MSC like cells, but as compared to the MSCs, they are very less immunogenic, and they have got properties which may be useful in many disease models. So we were the first in the world to translate these amnion cell therapies into the human, and we did a first in human trial of allogeneic amnion cells in premature babies with bronchopulmonary dysplasia, with established bronchopulmonary dysplasia, which is chronic disease of uh, prematurity. And Rebecca Lim was the scientist who helped us move this into human trials, and then we did 2-year follow-ups of that therapy as well. Now, you might think that these are small trial. What did it mean? It meant a lot because this opened the door for amnion cells to be used in a number of conditions, including adult conditions like pulmonary fibrosis, cirrhosis, inflammatory bowel disease, stroke, and so on. So it kind of opened the door for amnion cell therapy to be trialed in a number of conditions. And at the moment, we have just finished a dose escalation study of these cells in babies at risk of bronchopulmonary dysplasia. The first study was in babies who had already established BPD, and now we have finished a study in babies at risk, and we used a dose escalation design to see what is the safest and most possibly potentially effective dose. To get the final answer, obviously, we need a randomized control trial, but this was a dose finding study which is just completed, and hopefully we'll present the results very soon or later this year. Now, I've summarized probably a decade's work in a couple of slides. There was a lot of ethical and regulatory hoops to cross, and that is beyond the scope of the discussion today. But what is really important is moving uh, these therapies from the preclinical to the clinical world takes a long time and careful consideration. And in the meanwhile, what we are working on with amnion cells is we are trying to look at the packaging material of the amnion cells or of any stem cells for that matter, the extracellular vesicles, and potentially using them as therapy. So we have preclinical trials ongoing at the moment where we are using a conditioned cultured extracellular vesicle uh, 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 product to see if they can produce similar effects in our preclinical models as the amnion cells had done before we moved it to clinic. So watch this space for more work on the amnion front. I'm going to shift gears and move on to umbilical cord blood and tissue. And for the purposes of today, I'm just going to focus on cord blood. So the umbilical cord blood is obviously available in most of our babies when it comes to their birth. In a very few babies, there is no umbilical cord blood present because they've either had a cord accident or a placental accident that there is no cord blood available. But in most of us, we have a lot of cord blood present at birth. And as you know, cord blood has been used for a number of conditions over the last few decades, mostly for hematological or oncological conditions. But the fraction which we are most interested in that work or in this work which we are doing is the buffy coat. So when we spin down cord blood, you'll get the red blood cells and the plasma, and in between that is the buffy coat, which contains the nucleated cells. These are white blood nucleated cells mostly, but most importantly, they contain a number of stem cell or progenitor cells which have got high healing properties. The hematopoietic stem cells is what the hematologist and oncologist have used over decades for regenerating blood related cells, but there are also a number of other cells, including mesenchymal stromal cells, which are present in the cord blood, which can have those potentially effective properties to help with certain conditions. So the condition I'm going to focus on for today is perinatal brain injury, which is brain injury related to gestation or soon after birth in the perinatal period. And this is just a systematic review from our group, which focused on all the preclinical work which is present in perinatal brain injury, where they have used umbilical cord blood derived therapy. And I'm not going to take you through all of the results, but basically this schematic shows how for almost every condition or every parameter which we looked at in those preclinical models, whether it was the infarct volume, whether it was signs of inflammation, signs of astrogliosis or cell death, signs of neurobehavior, cord blood derived cells were showing benefit in almost all those studies which were done. 55 preclinical studies. Unfortunately, the quality of evidence in preclinical study continues to be low to moderate certainty because of how we report those studies. But it's fair to say that they're showing a lot of promise, and obviously moving preclinical work to clinical work is always challenging till you do the right trials and the right methodology. So all those photos which you're seeing are members of my lab group. Lindsay is a neonatologist with us and a PhD student of our group, who basically moved one of those therapies into the clinic. And before he did that, he reviewed what are the various cord blood and cord tissue derived cell therapies which are already in research practice in neonates. And basically, you can summarize them into brain related, lung related, or heart related conditions. And there were a handful of trials before we started to do work in this area, around 12 trials before we started our first trial, which was the cord safe study, which was autologous cord blood derived cells. We were trying to establish safety and feasibility in extreme preterm infants. So no one had done this kind of work in the extremely preterm population, the population, as you can understand, which is at highest risk of brain injury. These are babies who are born less than 28 weeks, mostly less than 1 kilo, and they have a significant risk of developing brain injuries, which impacts their long-term future. So, just to walk you through quickly through this research, what it involves: autologous cord blood cell therapy production and infusion. Cord blood is collected after preterm birth, generally after cord is clamped, and Himanshu, my co-lead here, had a lot of work done on delayed cord clamping. So once the cord is clamped, after however minutes or seconds it's done, cord blood is collected, it is spun down, the buffy coat is extracted, those cells are isolated and identified, and when good quality cells are present, we store them in a vapor phase system with DMSO, which is a cryopreservant. And once the baby is ready to get their infusion back, those cells are brought across to the hospital facility. uh, they are thawed, DMSO is removed, and they are resuspended in a dextran albumin solution to be able to infuse to the baby. So it all sounds very simple, but you can understand a number of labs and processing facilities which are TGA approved need to come together to be able to produce these cells in a manner which is safe for the babies. So what we realized while doing this trial very quickly was that the amount of cord blood we obtain, and the cells which we harvest for them for regenerative application depended on the baby's gestational age as well as their birth weight. More so their birth weight as compared to the gestational age. But what was very heartening to see was that in more than 70% of these babies, we could get enough cord blood cells, which we thought could be of therapeutic value when it came to infusing these cells to them. So last year, at the end of last year, we published in the Lancet the cord safe study, which I said was a world first study, which showed the feasibility as well as safety of cord blood derived cells in extremely preterm infants. And our feasibility in the trial was more than 84%. Once we had good quality grade cells which were going to be given to these babies, that came around to around 70-75% of those babies where cord blood was attempted had cells which we could transfuse to them. So that's a really positive outcome from the trial, and it was safe in all babies. There were some cell product issues, but no baby related safety issues which were identified. Now, this is a small study of 23 babies, but this is really important because this has led to the Cord Cell RCT, which has just commenced recruitment in Victoria, an international RCT, including countries, sites in US, Canada, Singapore, and across Australia, a number of sites in Australia as well. And we hope that Sydney is one of those sites which comes across board as well, where basically we are randomizing these extremely preterm infants where we get enough cord blood cells to either the treatment group or placebo, and the main study outcome is going to be the baby's survival at 2 years without major neuro disability. What is important though to understand, as I mentioned, is that 70% feasibility does not mean that every baby has got access to these cells. And autologous collection itself can be challenging. So if you look at the consort diagram for cord safe, it shows that in almost 50% of babies, almost 50% of babies, either we could not approach the families to consent them for the trial, or even if we had consent from the trial, cord blood could not be collected in enough volumes to have enough cells present. So that's really important. So it is possibly that cord blood autologous therapy might be an option, but in 50% of them, we may not have an option of even using their own cord blood cells. So we are doing the allo trial led by another one of my PhD students, Abdul Razak, where basically we are looking at any preterm infant who has these are babies born less than 37 weeks who have significant brain injury, severe brain injury, generally severe grade intraventricular hemorrhage or significant white matter injury, which we know from our follow-up studies are correlate with significant neurodisability or neurodevelopmental disorders. And what we are doing for the first time anywhere in the world is that we are using publicly donated cord blood, where the donors have agreed to use their cord blood for research purposes, not just for approved clinical condition. Is that we are using the Oz Cord Bank, the BMDI cord blood bank located at Murdoch and in Parkville, to be giving them a allogeneic cord blood infusion after partially matching their HLA and with enough cells in them which we think might be of therapeutic value. So the questions we are looking at is it even feasible to match these babies with donors with partially matched HLA? And then if there is any serious adverse events, especially when you give allogeneic product, graft versus host disease is a significant problem. And I'm happy to report that this trial is 1/3 through its recruitment, and so far we've had 100% feasibility and no safety signals so far. But obviously it's early days, so we need to complete the trial to be able to move on to the next level. Now, we are very aware that cord blood might be a great game changer, but sometimes we do not have enough cord blood cells. And when we start doing more studies, it is possible that we need even more cord blood cells. So at the same time, in the lab, we are working on expanding these cord blood cells so we can use proprietary available products to culture them in culture media to produce 500 to 1,000 fold increase of their cells, and then we can study them in vitro and in vivo to see if they're effective in doing the same thing like I mentioned cord blood cells were doing for perinatal brain injury. And this product is actually being used in a lot of adult conditions already, especially graft versus host disease. So it's a promising uh, area of work. So to summarize, just the cord blood side of things, we are in autologous cells, we have an RCT going, which is great progress. In allogeneic cells, we have a safety study going, and in the expanded cells, hopefully, if everything goes well, we'll have future clinical trials. I'll just like to end by sharing that we are very active in this space. We run a neonatal cell therapy symposium every year or two. The first one was held in Melbourne in 2022 with great speakers, including Dr. Bernard Thibault, who is a world expert in mesenchymal stem cells for bronchopulmonary dysplasia. The QR code from the proceedings of this symposium are present. Last year, we held it in Sydney at the Cerebral Palsy Alliance. I thank them for their support. And again, we had great speakers from the UK, from Europe, and from Japan, and those proceedings are also available. And this year, if any of you are interested, please join us in Noosa in Queensland later in the year, where we have a joint Australasian Brain Club and Newborn Cell Therapy Symposium happening, and there is a QR code for you to register or join us if you're interested. Please feel free to reach out to me, and I hand over now to Himanshu to take it forward from a global perspective and from a Sydney perspective. Thank you so much.
Thank you, Atul. So can you see my slides? Perfect. So look, thank you, Atul, and congratulations to your team for leading the world in this space. I work very closely with two stem cell scientists in Sydney. One of them is Dr. Madison Payton, who is probably in the audience, a Fulbright scholar, and Dr. Megan Finch Edmondson, who is from Sydney as well, who is the lead for regeneration team at Cerebral Palsy Alliance. And I would like to acknowledge their input into my presentation today. So my job is to take you on a world tour of stem cell use. Now, we will be very selective in our destinations, otherwise we'll be here for the whole day. You have heard Atul, talking about different phases of the trial, and I'll continue talking about it, but I would just like to start by stating what the different phases mean. So phase 1 trial is when you assess the safety and determine the dosage. And generally the number of participants are few. In phase 2, we evaluate efficacy and further assess safety. And there are more patients in this kind of trial. And the final phase 3 trial is where we confirm the effectiveness and compare it with the current standard of care. And generally in these phase 3 trials, you see several hundred to 1,000 patients. So I'll be briefly talking about the use of stem cells targeting the following organs in neonatal medicine: brain, and I'll talk more about the brain and provide just an overview of heart and the lungs. Now, I do acknowledge that there is some work in other areas. There is more interest like necrotizing enterocolitis, but for the interest of the talk today, I'll be focusing on brain mainly. Now, some of you in the audience who work with high-risk newborns know that there are three conditions that we deal with and worry about the most are intraventricular hemorrhage, stroke, and hypoxic ischemic encephalopathy. Now let's talk about intraventricular hemorrhage, which Atul briefly talked about as well. And this is the graph from the freely available Australia-New Zealand Neonatal Network 2022. On the horizontal axis are the completed gestational age in weeks, and on the vertical axis is the incidence of intraventricular hemorrhage expressed as percentage. And as you can see, I've highlighted there, less than 25 weeks, the incidence of IVH, and especially if you look at the dark blue bars, which is grade 3 and grade 4, which is a severe form of IVH, it's around 15 to 30%. And this equates to around 90 babies every year. Now, currently, we have very limited options to offer to treat IVH. Now, our first destination on this world tour is going to be South Korea. And this group from South Korea completed a phase 1 study. Now, again, just to remind you, phase 1 is safety and dose finding in 9 preterm infants with a mean gestation age of 26 weeks and a birth weight of 800 grams. They performed intraventricular transplantation, which means that they administered this umbilical cord blood derived MSC or mesenchymal stem cells using a needle through the anterior fontanelle directly into the ventricle. So, a reasonably invasive form of treatment. And what they showed in 9 patients is that there were no serious adverse effects or dose limiting toxicities. They have now progressed to a phase 2 randomized trial. Again, the population remains the same, preterm babies with IVH. And the outcome for this phase 2 trial is death or need for ventriculoperitoneal shunts in addition to brain MRI. Now let's go to the second condition, which is stroke. Now, how common is stroke? It's about 1 in 4,000 live births. Often you will have a well baby that will present with seizures on day 2 of life. And we generally provide the terrible news to the family and say that your baby is likely going to develop cerebral palsy. And we have no other options at this stage apart from some supportive treatment or symptomatic treatment. Now, this is in stark contrast to the well-established stroke protocols in the pediatric and adult population with many therapeutic options. Let's continue our journey westward from South Korea to Utrecht in Netherlands now. This group from Netherlands, led by Lisan Park and Manon Benders, did the first phase 1 study in 10 full-term babies with stroke. This is an open-label intervention study. They used bone marrow-derived mesenchymal stem cells, and these were administered intranasally within 7 days of presentation. And again, they established safety. They also had follow-up MRIs on all those 10 full-term newborns, and they showed that there were no unexpected structural cerebral abnormalities. Now, based on the success of that PASSION trial, this group got funding for this project called iSTOP-CP. This is a phase 2 randomized control trial that is focused on both babies with stroke and hypoxic ischemic encephalopathy, comparing intranasal mesenchymal stem cells to placebo. And they're measuring long-term developmental outcomes at 2 years of age. So this is quite exciting. And I was lucky enough with a couple of my colleagues to go and visit this center and see their really impressive cell manufacturing facility. So going to the third devastating brain condition that we as a neonatologist deal with is hypoxic ischemic encephalopathy. And if you look in 2022, the report for the ANZNN, there were 376 babies born more than 34 weeks that received hypothermia for HIE. Now, hypothermia is the current standard of care. However, even after receiving hypothermia, up to 40% of these babies will have long-term disabilities, including cerebral palsy and intellectual impairment. So there is a need to look at other options. So if we move further west in our journey to North America now, Michael Cotton, Joanne Kurtzberg, and their team from Duke University did the first phase 1 study. Again, phase 1 is safety and dose finding of infusing intravenous autologous cord blood in 23 babies with HIE, and they established the feasibility. And then they embarked on a phase 2 RCT. And as I think Atul alluded to, they had to stop early because of the logistic for cord blood collection. Processing and infusion in the first postnatal hours was a significant barrier. So they pivoted off to off-the-shelf therapy, which is using mesenchymal stem cells that were derived by umbilical cord tissue. They completed a phase 1 trial of intravenous infusion of this cord tissue mesenchymal stem cells in 6 babies, and then they have now progressed to a phase 2 randomized control trial, now the results of which are pending. Again, there are many registered trials around the world looking at HIE and cell therapy. Some of these trials are either completed and some are underway. Now, just going away from brain, and this is just a very brief overview. We won't go into detail in the interest of the time. I work in a children's hospital, and some of you who are from SCHN may be interested in this. So we have gone through the worldwide tour. We returned back to Australia, and this is again the work done in Royal Children's Hospital, Melbourne. This was a phase 1 study in newborns with hypoplastic left heart syndrome. Now, hypoplastic left heart syndrome is a significant congenital heart disease where the newborns and the children need multiple surgeries, including the one in the newborn period. So this group did a feasibility study of administering autologous cord blood, again via intracoronary route, and they established the feasibility. There is one more registered trial in North America where they are looking at intravenous infusion in the cardiac biopulmonary circuit of allogenic bone marrow-derived MSCs. Now let's look at the lungs. Again, I'll be really brief. This is the only one slide, just giving you a snapshot of 4 published trials so far. There are 8 more trials that are registered. Some of them are actively recruiting and some of them have completed recruitment. If you look at these 4 trials that have been published, you can see the indication of all this is bronchopulmonary dysplasia or chronic lung disease, and half of them are phase 1, couple of them are phase 2. And if you look just at the route of intervention, 3 of them use an intratracheal route, and the last one uses an intravenous route. And the type of cells that was used is umbilical cord blood derived mesenchymal stem cells. So if we have to sort of wrap everything up, where are we in terms of evidence for neonatal conditions? I think we have a lot of phase 1 data coming out, and most of the trials are either in the phase 2 stage or they are in the planning phase for phase 3. And if you look at so far from all the trials that I have shown you around the globe and from some of the work that Atul has done, it's very noteworthy to see that the cell types are very different. Not only the cell types, the dosage used have been different as well. If you look for indications for the brain, the trials that were targeting brain injury, some of them have used intravenous route, some of them have used intranasal route, like the PASSION trial from Netherlands, or like from South Korea, some of them have used intracerebral, an invasive form of administration. For the trials targeting heart, the one trial that was published from Melbourne, they gave straight intracoronary during the surgery. And then if you look at the trials targeting the bronchopulmonary dysplasia or chronic lung disease, 3 of them use intratracheal and 1 of them use intravenous. So if you think about going forward, there are some challenges that we need to be mindful of progressing to phase 3 and beyond. I guess the first thing is that all the protocols need to have a rigorous safety monitoring. Now, this will depend again on the route and also the cell type used. We need to think about optimizing the cell type that we are going to use. And obviously, this will depend on what is the source, what is the ideal cell type for the target condition, what is going to be the dose, what is going to be the delivery route, and what is going to be the timing of administration. Is it going to be 1 dose or is it going to be multiple doses? Obviously, we need to be mindful of the parental consent and the vulnerability of the neonates that are participating in the trial. And I think this is a significant issue, which is the scalability issue. The manufacturing process for stem cell needs standardization and they need cost reduction. we need to think about equity here. Will this therapy only be available to centers that have cell manufacturing or processing abilities? And this is true especially for New South Wales and ACT, where we have 9 NICUs spread across the state. And what about the babies with brain injury born in low to middle income countries? I think that's where the industry partnership becomes important as well. And obviously, we have to ensure that we have long-term follow-up data for these trials, not only on sustained efficacy, but also on potential adverse effects over time. We need to be aware of the changing landscape of the trial designs, and maybe the adaptive trial design can accelerate progress while maintaining safety standards. Now, this is not a cliche, but collaboration is absolutely essential, not only with regulatory bodies, but also with industries, and also with our colleagues, including multiple specialists like transplant physicians, blood banks. Since there are trials going all over the world, it is very important that we harmonize our protocols and our outcomes. So not only we ensure reproducibility across studies, but also all the data could contribute towards individual patient data meta-analysis that may help us to answer some of the questions. I think one of the biggest advantage for this trial is the location of these babies. These high-risk babies are already located in the best possible place to receive this highest level of care. So they do not necessarily need to be transferred to a higher facility to receive this therapy for monitoring. I guess one of the biggest enablers is that the need for this work from our families and the babies, and also the clinicians. The clinicians would like to offer something more to this family, to these babies with brain injury, where currently we have very limited options. However, we do need to do this safely. I would just like to provide you an example of our attempt in New South Wales to address some of the challenges in New South Wales. Many of you may recall hearing about the NeoSTEM trial, which was a phase 1 trial of off-the-shelf mesenchymal stem cells for babies with neonatal stroke. So when I say off-the-shelf, which means that the product would be delivered to your doorstep in the newborn intensive care unit, rather than transferring the baby to a facility where we have the cell manufacturing facilities. Now, we got a buy-in from all the NICUs in New South Wales. This was a trial where we had one of the lived experience or a mother as the partner and as chief investigator. Now, unfortunately, the trial was withdrawn as the commercial partnership did not work out. However, we remain committed and interested in pursuing cell therapies for neonatal conditions in Australia. I guess what next? I think especially for Sydney and New South Wales, Sydney Children's Hospital Network can take a lead here in getting New South Wales ready for stem cell research. I think they are leading the world, and they have a proven track record of leading this work in advanced therapeutics, such as gene therapy work for rare diseases. We will need to get the clinicians, scientists, transplant clinicians, blood banks, governance body all together to develop standard operating procedures so that we can embark on stem cell therapy in a phased manner across New South Wales, so that we can participate in the trial that Atul is proposing. We can participate in a trial that Netherlands group are proposing to expand. And I can, disclose that we are already working towards achieving that. We are about to form a stem cell working group, which will develop standard operating procedures, at least initially for the Children's Hospital and then beyond. We need to partner with lived experience networks, and we will need to secure sustainable funding, including philanthropy and Category 1 grants. So I guess to conclude, stem cell therapy holds transformative potential for neonatal medicine, addressing clinical translation barriers through rigorous research, adherence to ethical standards, and multidisciplinary collaboration is crucial for success. Thank you very much.
Thank you very much to both Himanshu and Atul for those excellent presentations that not only curated a lot of the data sets that exist worldwide and in Australia, but also touched on some of those systems readiness and governance issues that can prove to be a challenge in this space. Now, I noticed that we have over 70 attendees at the moment, and just looking at the names, I can see that we have clinicians, we have researchers, we have people with lived experience or patient advocacy backgrounds. And certainly one of the great advantages of these webinars is allowing for interdisciplinary conversation. So I please invite any of the delegates who are online to please type your questions into the question and answer. And if you don't have a question, you can also view other people's questions and up rank them so that we can get to those this afternoon. And we do have about 20 minutes or so for questions and answers, which is excellent. So whilst I'm waiting for people to think about their questions and crystallize their thoughts, I might just ask one question to both of you. And sorry, I realise I haven't actually introduced myself. So for those online who don't know me, my name is Dr. Michelle Lorenzos. I'm a paediatric neurologist based in Sydney, and I'm also the Advanced Therapeutics Medical Lead at the Sydney Children's Hospitals Network. So it's excellent to have been able to hear this material today and to moderate this question and answer section. So the question that I wanted to ask you both was, we understand that there is, in pediatrics in general, but particularly with neonates, there is a desire to make sure we only offer safe treatments and that we protect them from any procedures or trials that may be problematic or risky. And I guess that's important to balance that between the desire from our clinicians, but probably most importantly from the community and the family about looking for better treatments for patients. And I was just wondering if you could speak at all to the data or experiences around the community preferences to look at stem cells as a potential treatment option for neonates and children.
Yeah, I'm happy to start, Himanshu, if that's okay. So thanks, Michelle. I think that's a really important aspect to consider. Most of the studies we do, we have consumer or people with lived experience input. I think it should be from the start design of the studies itself, which is so crucial. And now I'm in a very lucky space. Like I said, we are very active in this space. So we've got families who've had those cell therapies themselves, also part of the consumer group. So we have a group of our families whose babies have had cell therapies, also now part of consumer groups, both as a focused way, but also in a general way. So I'm in a very lucky space. But I think whenever we talk to families, whenever we talk to the consumers in ethical institutional review boards, the single message which comes across is that we should have the option to consider these studies. I think for me that is the bottom line. You would have remembered during the pandemic there was a lot of consideration around involving children and pregnant women in trials. The same applies for any condition, whether it's premature brain or lung, heart, or whatever else. So I think not having them as options because this therapy might be too unsafe or too tricky for those conditions, I think is a failure on the community if we do not involve them. So I think whenever we have tried to approach families, they are very open to it, and you'll be surprised, they are much more learned than what we expect them to be in those things, because there is a lot of material out there on the web which people access, and they know what other countries and other units and research groups are doing. So I think like Himanshu might want to add, if New South Wales doesn't come on this bandwagon, those families are missing out. And that's what's happening to a number of our families, that they choose to seek these therapies overseas, sometimes paying thousands of dollars, and with sometimes untrusted therapies, because they are just so desperate. So I think having them involved in the design and then being open to having those discussions is really, really important.
Yeah. So just a couple of points in addition to what Atul said. You may have heard this. I think there's a review article, and I heard this in one of the presents talk, is that nothing about us without us. And I think the families now, and I could say, and I know that Kylie Facer was part of the NeoSTEM group, and she won't mind me taking her name. She was a chief investigator, and she was the co-lead for the NeoSTEM trial when we designed. And we had her present for every site meetings, and she was there to sort of provide her perspective rather than we feeling or explaining what they are feeling. I think at the end of the day, if you ask me, the safest way to do things is by doing research, because there you have a protocol. It has gone through a peer review process. It has gone through the ethical bodies. It has gone through the governance bodies. And that's the safest way. Otherwise, as and I'm sure Megan Finch Edmondson, when I talk to her, she has many examples of families, especially with cerebral palsy, that are traveling overseas, and we don't know what they are getting. I think we owe it to these families to do it in a research setting in a safe way. So I think they can speak for themselves. They are with us in this, and we need to all go together.
Fantastic, thank you. So I have another question in the Q&A, which is somewhat related to talking about risk, and it's actually recognising that in order to do some of these clinical trials, we do sometimes need to partner with industry, and we know that industry can be sometimes particularly cautious, and how do we encourage our industry partners to become more involved or supportive, or to build those partnerships with industry that can be required for these trials?
Yeah, that's an excellent point. We are very fortunate again, Michelle, to be working with one industry partner, in this case, Cellcare Australia, which is part of the Cooper Surgical Group in the United States. And they run the private cord blood bank, for example, and partnering with them has been really useful. There are two types of industry involvement, which people I'm sure are already aware of. One is investigator-initiated industry partner trials, and the other one is commercially sponsored trials. And I think neonatology particularly has been very risk averse when it comes to commercially sponsored trials, but it is changing. In my time in the cell therapy space, I'm pleased to report that we are getting uh, commercially sponsored trials in the cell therapy space, but also in novel therapeutic space in neonatology like never before. So it is an expanding field. The problem with neonatology, as you know, it's a very small field. So just to put it in perspective, 300,000 babies might be born every year in Australia. Less than 3,000 are born less than 32 weeks. Less than 1,000 or close to 1,000 of them are born less than 28 weeks. So, it's a small space. So if I'm investing money as a venture capitalist, I would not be putting in neonatology. I'll be putting it in heart condition, in diabetes or something else much more lucrative. So the problem with us is it's not that we are averse, it's the industry which is averse. But I think it is changing with the realization that in the first world, definitely a lot of places are providing care to extremely preterm infants like never before. We are resuscitating 22-weeker babies, and they're surviving with mostly good outcomes. So I think the field is changing, but also the realization that these babies, when they survive, are the ones who are having long-term problems. So even though the numbers are small, they all add up later on in life with the dollar burden on their care. So I think industry is coming around to that, and I think we'll see more commercially sponsored. We are in discussion right now about a commercially sponsored trial in our space as we speak. So I think we are going to see more of them. But yeah, you're right. To date, this has been low, but if we are open to discussions, I think that's the same thing with the families, the same thing with industry. If we don't open up to discussions, it's the babies and the families who miss out if we are just going to say, I'm not going to have any industry sponsored trials.
Yeah, and just to add to that, I think when we talk about neonatology, it's about return to investment. I think we are talking about beginning of a lifespan. We are going to contribute the babies that we look after are going to be contributing to the society. And I think that's a fantastic investment opportunity. Yes, I agree the numbers are small, but we are really changing the lifespan here. And also, Michelle, that's where some of the expertise that you bring and also the SCHN, because you deal with rare diseases, like spinal muscular atrophy and all those conditions. And what SCHN has done is to come up with a successful model. So that's where we need to, as a clinician, I will need help here, and that's why it's great to be in an institution which has probably led the world in this field.
Fantastic, thank you. I also have another question here from Professor Geraldine O'Neill. So changing tact now, we've talked a little bit about, I guess, risks and partnerships with our community and with industry. But Professor O'Neill was asking, how long is the follow-up period for babies who've been treated on stem cell clinical trials? And what types of things are standardly monitored? And I suppose as a neurologist, I was thinking about this as well in terms of you monitoring for things like pediatric stroke or neonatal stroke, I should say, where we know the outcomes can be really quite heterogeneous. So how do you know if it works, I suppose, is a question. And then thinking about what the follow-up is and what things that you're monitoring for these little ones.
It's an excellent question. If all trialists were given unlimited funds, we would obviously follow them up for life. But as you know, most of us are limited by the funds we are given. So generally, follow-up is for 2 years. That is a general follow-up. And in fact, Himanshu, it's for most neonatal conditions that we follow up for 2 years, because that's the timeline we have for our grants. That's the timeline which we are able to see these families, because our standard clinical care is up to at least 2 years in most settings. So that's the minimum. Uh, in some of our trials, especially the safety and feasibility trials, the trial monitoring protocol can be very exhaustive. So, for example, the allo trial, which is giving allogeneic cells to babies, we see them on almost a monthly to 2 monthly basis. It's so extensive that the poor families, we reimburse them for their time and their parking and things like that. But it's the families, goodwill and altruistic nature which comes to this. But what we are monitoring for, coming to the most important thing, what we're monitoring for in those trials is safety, which is, for example, in the allo trial, graft versus host disease, any other potential side effects, are they having any other potential s- uh, uh, side effects which we are not even thinking about. So it's rigorous clinical exams, lab testing. We do things like full blood counts, liver function tests, kidney function tests, uh, chimerism assays we have been doing to see what amount of donor DNA or cells are staying in the system for long. We do graft versus host disease cell subtypes sometimes if we start seeing any changes in their white cells, for example. So there's a number of things which we target depending on the cells which we are giving, and also the condition which we are dealing with. Obviously, the efficacy signal, as you can understand, Michelle, is going to be looking at their brain outcomes. Number of them will have imaging, they'll have follow-ups with the standardized assessment tools. But it's fair to say, beyond 2 years of the cell therapy, it becomes really challenging. Sometimes we've been lucky to get extra funding to see them at school age, because as you can understand, the heterogeneous aspect of it means that it's not just the physical motor problems which are going to be the key. It's learning, it's behavioral, which, as you know better than me, they happen much later. So trying to follow them up for later, it all depends on. In the small trials, we are able to do it because our colleagues from neurology and behavioral pediatrics are able to give us time for those limited number of patients. But when it comes to hundreds of babies, it can become challenging. But yeah, absolutely, very important point.
Agree. And in addition to the limitations, to do it within the framework of a trial, I think we have to be then creative and to think about linkages, to either the NAPLAN or thinking about hospital admission data. And, there are ways around. And I think it'll be good to think about this when we are putting a grant application as well, that we will consider in future, so that the reviewers are aware that though we are thinking short term because of what you're giving us, in our mind, we are already thinking long term.
Thank you. And there's actually more of a comment in the Q&A that really reiterates that importance of longer term follow-up when it's feasible, and that often we know with neurological events in children, or certainly neonatal outcomes, that it is often those more executive functioning or behavioural aspects or school performance issues that are the more discriminating factors. So thank you for that online contribution.
Yeah. And
sorry.
I just want to add one more point, and thank you. I think it was Professor Key Louis, who asked, who made that comment. A very important thing which we also include in our studies is, we may not have resources sometimes to follow them up to 5 to 10 years, but we have very good early markers. And as you know, Michelle, one of the best early markers is MRI, and MRI in particular regions of the brain can give us very good prognostic information for long term. So I think that's really useful to have. So we try to build those early biomarker studies into the follow-up so that we can actually have some more risk stratification for their long term. But the best way, like you mentioned, is obviously building up those frameworks for everyone.
And
Thank
I'm
you.
going to say, Key Louis, he's the chair of the Australian New Zealand Neonatal Network, and that's a well-established registry that collects the long-term outcomes of preterm babies around the country and New Zealand, and there is maybe Singapore and Hong Kong part of that as well. So if there's a support of established registries already, then it also helps with the cost and everything. So it's good to have support of key organizations like ANZ.
Excellent. So I can see that we probably have time for possibly one more question. And so we've spoken quite a bit about the stem cell specific follow-up and the needs around clinical trials. I suppose one of my particular areas of passion is thinking how we bring innovation and new treatments into the health system. And so I guess I want to ask both of you, Atul, from your experience of how you've managed to do that, if you had to give a kind of one key piece of advice in terms of bringing innovation and new ways of treating into a health system, what would be your key advice? And I guess, Himanshu, what do you see as the key priority for Sydney moving forward along that same theme?
I've got two pieces of advice, Michelle. One is you need to think about the babies and families. So if you don't have a champion, I'm not saying I'm a champion, but we need to have passion. Nothing happens without passion. So driving passion is not easy. You have to have that, people who are self-driven to actually make a change. And I think those come from within. So people who are listening, I'm sure you look after babies and families all the time, and don't ever think that you can't do it. Anyone can do it. You just need to feel it. So that's my first bit of advice, is just uh, you know driving your inbuilt passion, innate passion. That's the starting bit, and then after that it becomes pretty easy. I would say the road might be very long and windy, but it's very easy. Then you just find like-minded people with you in every bits of those teams, and it's probably a village which it takes for everything, in the ethics committees, in your clinical teams, in your consumer lived experience team, in your research labs, in the organizations you work with, in the industry you work with. You just need to build those partnerships right from the start, because it's almost like you need to work backwards. You think of the final product and you think, what all steps will it take for me to get that final product? And I just want to highlight preclinical scientists, which is almost a dwindling entity right now in Australia because of lack of funding from the government, I think are key to here. So I've been very privileged to work, and I did my PhD in preclinical science to be able to work with those smart people who actually do that groundwork to be able to set up discovery science. I think that's really key. So I think uh, all those partners are really important.
Well, I was going to say we should give a job to Atul, but Sydney. But I'm just going to say that having families on the table will drive the innovation, because that's where clinicians and even administrators, even the regulatory bodies, when they see the families on the table, it makes a significant impact.
Thanks so much, Himanshu. And I can see that Professor Kilui also wrote a comment about establishing good data collection of rare disease in emerging novel treatments in general. And I think that's a really great place to round off this discussion, because we're speaking about, I guess, scientific analysis and interpreting data and their systems readiness about stem cells, particularly in neonatology. But as we get better at I guess, streamlining these pathways in terms of embedding new processes into our system, it stands to benefit not only those little neonates, but also other children who are living with rare conditions as well, as we streamline these approaches, which is really what the Kids Advanced Therapeutics program is all about. And so we're incredibly grateful for your time. And I might just hand back to Professor Paula Bray to close the webinar.
Thanks so much, Michelle. And I just want to really thank both of you for your time and excellent presentations today, and to Michelle for your expert guidance through the questions, and importantly to everyone in our audience today for joining us. Just a reminder, the video of the webinar will be available via our website at the Sydney Children's Hospitals Network YouTube channel. There'll also be a short survey at the end of the webinar, which will automatically open in your browser once the webinar webinar ends. So if you have a moment, please fill it out. We really appreciate your feedback and suggestions. And I'd like to, most importantly, thank our contributors, including the Luminess Alliance and the Sydney Children's Hospitals Foundation for their support of the Kids Advanced Therapeutics program. And importantly, thanks to all the people who have contributed in bringing today together. We really look forward to keeping you updated for our next webinar. Please subscribe to the Research Interest Group mailing list via the QR code, which should be on your screen. And that's probably all for me today. Thank you again for coming along. Thank you for the presentations, and we look forward to seeing you again at the next webinar. Thanks, everyone.
Thank you.
Thank you.